Wonderful. Good afternoon, everybody. I'm so pleased and humbled to be here today to speak about a topic that is near and dear to my heart, especially as a physician and a Black woman. As many of you probably know, we are currently in the midst of what I think is one of the biggest health crises in this country, and it's regarding maternal mortality and maternal morbidity, one that is almost exclusively highlighting disparities. The CDC, for example, says that Black women are dying in childbirth and pregnancy-related causes 2 to 3 times more than their white counterparts. And this is not something that we should ignore. I'm really excited, though, to have an expert in the field of reproductive health to kind of walk us through what these inequities look like and what is going on and where we can go next. Dr. Jamila Perritt is a fellowship-trained OBGYN, and she has a comprehensive background in family planning and reproductive health. In addition, she is the president and CEO of Physicians for Reproductive Health, which is an organization that works to improve access to comprehensive reproductive health care across the nation. She is a trusted voice in the field, and I actually am a huge fan of her. I've seen her being interviewed and heard her speak to NPR, Vogue, Vox, so many other media outlets based on her expertise. She received her undergraduate degree from Brown and completed her medical degree just south of us here at Howard University in DC. And she did her residency training at Pennsylvania Hospital. And then her family planning and Master of Public Health right here at the Johns Hopkins University Bloomberg School of Public Health. We are so humbled to have her today. And so let's turn our attention to the conversation we're about to have. I know many of us here, Dr. Perritt, are familiar in some way, shape, or form with what the Black Maternal Health Crisis is, but do you mind just defining what is the Black Maternal Health Crisis and maybe contextualizing why it's an important topic to understand just in general in the framework of all health things?
For sure. Thank you so much, Dr. Bervell. Thank you for inviting me. It really is my honor to be here, to be in conversation and community with you and all of you who've taken time to log on. There are a couple of things that you mentioned in your introduction that I think are relevant in response to that question. The first one is really, what are we talking about here? And you use both words, you use disparities and you use inequities. And I think when we're talking about the maternal health crises in this moment, it should be super clear that we are honest about what is happening and why it's happening, right? And so when we think about disparity, all of you all are public health folks, right? And so, disparities simply are differences. And so, folks that are showing up for care, who have different environments and differences in outcomes is what we're talking about when we say disparities. But when we talk about inequities, we're talking about health outcomes that can be prevented if we were operating within a justice-grounded framework. And I think that piece is really important as we lead into this conversation about Black maternal mortality specifically, because what we're talking about is the context of our lives. If anyone has read the Combahee River Collective's Black Feminist Statement, there's a line in it that states very clearly, it is the context of the circumstances of our life that creates the context, right, of our oppressions. And so really understanding that is how we got here, that's what we're talking about. We can talk all day about the numbers, and you've given us some of those, right? Black women die 2 to 3 times greater, and in some places it's much, much more significant and inequity. In places like New York, for example, and Mississippi, we see huge inequities in outcomes regarding morbidity and mortality for our communities, for Black women in particular. There is no one reason why this is occurring, but we do know why it's not occurring. It's not because I'm Black that puts me at risk. So it is not my melanated skin that means that I have a greater chance of dying. There's not a biological cause to this that can explain away these inequities, but instead is the racialized experience that Black women and birthing people and Indigenous women and birthing people have within the healthcare system that creates the conditions for these inequities to really manifest. The other thing that I think is critical to lift up is that this is not new. We're talking about it now for sure. And it's really reached a public conversation. And I want to say really explicitly that that is not by accident. We are not now hearing about this because folks are just newly interested in the topic and have the political or social will to discuss, but it is a direct result of the frontline on the ground organizing of Black and Indigenous women, mostly in the South, who have really been ringing the alarm about this for many, many, many years and saying it is not race that puts us at risk, but racism. And so all of those things are really important to underscore when we're talking about the what and when we're talking about the why.
Thank you so much for that framework. Before I kind of throw a curveball at you, I do want to just have you remind people, why is it so important to talk about Black maternal health at the intersection of all other type of healthcare, right? We're public health people. Some people here might not really care about maternal health, but they might be more interested in transportation or more interested in education. What is the intersection of this topic with others?
So we all live intersectional lives. I can't talk about what it means to be a Black person in this country and not talk about what it means to be a female-bodied person in this country. I can't talk about what it means to live and to grow up in the District of Columbia and not talk about what it means to be a young Black girl growing up during the war on drugs and thinking about the impact of gentrification, of economic insecurity, of environmental injustice. All of those experiences, all of those conditions shape the person that I am today, and certainly the doctor that I am when I'm providing clinical care. And so we can't talk about them separately. They don't happen separately in our patients' lives, and so they cannot be discussed in a way that is siloed or separate in our work. The tricky part here is that often people hear this and then they feel overwhelmed. Well, I'm here to talk about maternal health. I don't want to talk about transportation. I can't talk about housing justice. I can't talk about environmental justice. That's just too much. And I would love to refer to, I don't know if anybody has seen the Toni Morrison movie, The Pieces I Am. And in that movie, they're interviewing her and she's talking about the time that she was writing Beloved. And at the time, she was writing in the middle of the night, writing this beautiful, amazing novel, culture-changing novel. She was also teaching academically. She's a professor, right? And she was an editor at a publishing firm. And so the interviewer asked her, you're doing all of these things, you're writing this book, you're teaching, you're editing. How are you able to do so many things? And her response is, they're not a lot of different things. It is all the same thing. And so when we're talking about maternal health, when we're talking about all of these intersections, it's critical to understand we're talking about all the same thing. This is about justice in every part of our lives, because it is what we deserve as human people in this world, whether we are pregnant, have the capacity for pregnancy or not. We all deserve to be able to certainly live and survive our pregnancies, but much more than that, and deeper and further and beyond that as well.
Thank you for that reminder. Last summer, when the overturning of Roe versus Wade happened, I think a lot of people pointed to that intersectional nature and that dynamic nature, specifically of reproductive health. And so I am wondering, how and what role did overturning Roe versus Wade play on pregnancy outcomes for Black childbearing and pregnant individuals, if at all?
Yes, the short answer is absolutely. It played a huge role and continues to do so and will for generations to come. One of the reasons I'm so happy about this question in particular is because often we talk about abortion access specifically as if it were separate, different, othered from other pieces of reproductive health care. We know that most people who have abortions are already parents, and so they know what it means to parent children. Most have carried a pregnancy to term at some point in their lives. And so we're not talking about people who have abortions and people who have babies. These are the same people. These processes, these experiences are occurring in the bodies of the same individual. We know that at last count, 1 to 4 to 1 in 5 women will have an abortion in their lifetime. So it stands to reason that most people who are pregnant, who carry a pregnancy to term, will also need or have had an abortion in the past as well. And so these issues are deeply connected. From logistical standpoint, what does it look like? What does it mean when you ban abortions? I find it particularly disconcerting and hypocritical when we look at the places where these abortion bans are rolling out most aggressively under the guise of safety and well-being, particularly for the protection of women and families. This pro-family language that is used to advocate for the elimination of a basic human right to determine whether or not you will be pregnant or not. And these being used as excuses are the exact same places where we see huge inequities and outcomes for maternal health as well as infant health. So if indeed you were pro-family and pro-life, then it stands to reason that you would be funding housing for folks and not supporting efforts of gentrification. It stands to reason that you will be supporting transportation infrastructure so that people can get their children to appointments. You will be supporting paid family leave. You would be supporting childcare. You would be supporting the things that it actually takes to be pregnant, to have a child, and to raise a family in this country. And so those things run in parallel. Right? We see these inequities in abortion access that are mirroring the inequities and outcomes for maternal and fetal health in these same communities. And it is because they are deeply connected and they are so in our lives and in the lives of our patients. The last thing that I'll say about that is just really drilling down into the data. We have really strong evidence that when we ban abortion, maternal mortality increases, period. And that happens for lots of reasons. One certainly is because diminished access. When we think about abortion providers like me, we often provide a wide breadth of care. Many of us are practicing general obstetrics care, as well as gynecological care. And for folks who are particularly abortion providers who are now being targeted for punishment and penalization for providing abortion care, we are finding more and more are being forced to leave the state. When OBGYNs, when family medicine doctors, when internal medicine doctors, when pediatricians who also provide abortion care are leaving the state because it is not safe for us, it's not safe for our families, it's not safe for our communities to provide this care, then the care in that state decreases as well. The access to care decreases. We also know that for folks who seek abortions and are turned away, and this is really beautiful evidence out from the Turnaway study out at UCSF, that looked at people who had sought abortion care, were unable to obtain it, what happened, and it followed folks longitudinally, decades out in their life. And what we know is that for people who seek abortion care and are unable to obtain it, they have lower economic and educational attainment. They're more likely to be tied to abusive partners, to be in situations where they are being harmed or experiencing violence, more likely to have substance use disorders, to have mental health disorders. So the outcomes are really clear. When someone says, I cannot carry this pregnancy to term, we should believe them, because the outcomes for individuals and communities are so significant and damaging.
I think that's probably one of the most powerful reminders, especially for all of us here as public health professionals in some way, shape, or form, seeing the problem in front of us, but the depth and the breadth of how it extends to someone's life is really impactful. And so with that in mind, and knowing what we're dealing with, not just from the repercussions of Roe versus Wade, but knowing what we're dealing with at the baseline and maternal health in this country, what can we do as healthcare professionals to, number one, adapt to the changes, because we are operating in a world where policy is in flux every day, but also, number two, advocate for these patients and these individuals and these citizens and residents of our community in a way that can improve and ameliorate the disparities and the problems that you so eloquently depicted.
So I think I would offer a couple of things. Like one, we, particularly following the Dobbs ruling and the overturn of Roe, the organizing for some folks has been focused on bringing back Roe. right? Restoring Roe is the language that we often use or we hear being used in advocacy and policy spaces. I want to say very clearly that Roe has never been enough. And so we can both simultaneously grieve the loss of federal protections, constitutional rights that have been lost through the Dobbs decision, and identify the fact that for people who lived in many communities, it was essentially as if Roe never existed. They were never able to access this care because of all of the barriers that have already historically been put in place. We saw the chipping away of this constitutional right for self-determination for our reproductive health beginning immediately after Roe was decided in 1973. And I would point to the Hyde Amendment as a clear example of that. The Hyde Amendment is not a constitutional amendment, but instead is a rider that's attached most often to appropriations bill year after year after year after year that says no federal funding can be used for abortion except in the case of rape, incest, or threat to maternal life. And what that means is that there's some communities that are particularly impacted by this. Certainly those relying on governmental insurance for their health care. So we're thinking about folks on Medicaid. But here we are in the DMV area. We have a huge community of folks that work for the federal government, also impacted. If the federal government is your insurance provider, if you have TRICARE, you also don't have abortion coverage because of the Hyde Amendment. If you work in the Peace Corps, if you work at an international NGO, anything that is funded by the US government. So there are huge swaths of individuals because of their insurance status, because of their nationality, because of their economic status, because of the community that they live in, because of their zip code, who have never had access to abortion. So the what to do begins with not advocating for the return of Roe. We have an opportunity now, as dark and desperate as this time is, to really reimagine a new system. A system where everybody gets the care that they need, not just the rich folks, not just the white folks, not just the folks that happen to know a doctor who lives in their community, right? Not just the folks who know OBGYNs, who can access the medication, but everybody having this opportunity. And so my advocacy, my offer for your advocacy is to come from that human rights framework. One of the things that I love so deeply about the reproductive justice framework in particular is that it is not abortion centric, it is not maternal health centric, right? And for those who may or may not be deeply familiar with it, if it's okay with you, Dr. Bervell, I'll give like a quick, is that okay? So reproductive justice is a term that was coined by 12 Black women in 1994. And they were attending the Illinois Pro-Choice Conference in Chicago, and they were talking about their lives in the context of international family planning, and clearly identified these connections with folks that are living in developing countries and under-resourced communities, not having access to reproductive healthcare services, and saw clear parallels in their lives as Black women in the United States. They came together and thought, what can we offer here to this work? And not wanting to use the language of choice, given that they represented communities that had no real choice. And remember, this choice language has been popular for a very long time, right? This false dichotomy, pro-choice, pro-life. But they said, this is no real choice here for our community. And so instead, they blended these terms, social justice, reproductive rights, and human rights, to come up with this new term, reproductive justice. Reproductive justice rests on 4 core tenets. Every person has the human right to determine if they will have a child and the circumstances and conditions under which they give birth. That's our maternal mortality here that we're talking about. Every person has the human right to not have a child and to have the information and resources necessary to prevent or end a pregnancy. Information and resources, right? So now we're talking about abortion access, but also enabling conditions that are the government and our society is responsible for providing. Every person has the human right to parent the children we already have in communities that are safe and sustainable and free from violence from the individual and the state. Here we're talking about economic injustice. We're talking about environmental injustice. We're talking about state-sanctioned and community-based violence. All of these things are deeply connected. And the 4th tenet is that every person has a human right to bodily agency and autonomy. And so we have to understand that these things in the minds of these Black women who gifted us with this framework laid a pathway for us to say, we cannot lean into the primacy of abortion access any more than we can lean into the primacy of access for maternal mortality. These are equally as critical issues and should be addressed, should be fought, should be protested around, should be supported in every single facet of our life. So the second piece of your question, right, and maybe what folks probably actually want to know is like, what can we do? And this is a question we get often, right? Like, so this is such a big issue. Let's be clear, we did not get here in the last year and a half or 18 months or 2 years, right? This has been, Black maternal mortality has been a 400 or 500 year issue. The idea that one solution will be a fix for this is false. You know, we've seen a number of initiatives that have had varying degrees of success. So for example, the American College of OBGYNs has a program called AIM, and I can't remember what the acronym is off the top of my head now. Do you remember?
I think it's like Alliance Medicine, I'm gonna guess, but I'll look it up and let you know.
And so what they've done is really work to standardize care in hospital systems for the top 5 causes of maternal mortality, right? So we're talking about cardiac issues, hypertension, we're talking about hemorrhage, right? All of these kinds of things. And so they said, we'll put these protocols in place. And so if somebody comes in, it's very algorithmic. The blood pressure is above this or below that, then this is the way that we move. And they've seen success. So what we've seen is improvements in maternal mortality and hospital-based care there. And that's a wonderful thing, right? I am not diminishing the impact of that. That alone is not enough, because when you unpack those improvements, we do not see them experienced equally for Black and Indigenous birthing women and people, right? And so the question is, how do we grapple with racism here? That is the question that is before us. What does it look like to actually interrogate our practices, our processes, the way we move within these systems, the way that we, as physicians, as activists, as advocates, as public health agents, uphold these systems of care that we know do not serve our communities. And so the beginning of this, one of the wonderful things about the organization that I lead is that it's an organization designed to call people to action. We know that physicians carry a lot of weight. We have a lot of power and a lot of privilege. And oftentimes, particularly within hospital systems, we feel like, well, I'm just one person. There's not a lot that I can do. Lies. There is a lot that you can do and a lot that you should be doing. And often you are holding some of the most amount of power of anybody within the system, whether it feels like it or not. And you certainly are holding more power than the patient you're taking care in front of you. So the question becomes, how do you utilize that power? Physicians for Reproductive Health's purpose is to organize healthcare providers. Right? I'm an organizer by training, and that is my background. Before I was a doctor, before I did any of these things, I was an organizer. And so organizing typically happens at the grassroots level, and that is critical organizing. The work that we do is also organizing at the grass tops level. So how do we move these things together? What does it mean to be a doctor with all of this power and privilege? And how do you leverage that to advocate for the communities who need it most? And how do you understand what the issue is, the nuances, the complications? You know, decisions about pregnancy, about abortion, about contraception are very complex and complicated. And so it is our role, our job, we have an opportunity to complicate the conversation every single chance that we get, to give it the nuance and complication that it deserves when we address it. There are no quick fixes. There are none, but you have power and you must use it.
Absolutely. You know, if I can summarize everything you said, essentially, whatever domain you are in, seek to improve that domain under the tenets of reproductive justice, recognizing it all works together to move and advance and improve the situation that we're currently seeing in the country. Ideally,
I think that that's great. And a great summary of it, right? They all work together. And so I can give you like a laundry list of things you should do. So you can implement these protocols. You should talk, share decision-making with you. Like there are lots of like ideas about what can happen. The first thing that I would offer is to really take the time to educate yourself about reproductive justice, about the framework and ideology, right? About what maternal mortality looks like in your community, about the relationship between the institution that you work with and work in has with the community that you are charged with serving. How do you understand that history? I provided clinical care at Hopkins for a number of years, and the conversations that patients would have with me behind closed doors when it was just me, a Black doctor, and them, a Black patient, are vastly different than the conversations that were had when there were other folks in the room, right? So these beliefs about, this recurring theme of Hopkins doctors stealing people from the street for experimentation. That isn't something that has gone away. That is a deeply held belief. If you are providing care in that community and you don't know about the legacy of your institution, you are doing a disservice not just to yourself, but to the people that you care for, because you're missing a whole piece of the puzzle. Take time to learn. Medical education is not designed to require you to learn about the community you care for. We move every 4 years. Right. So you mentioned in my summary, I grew up here in DC. So I did my, education here growing up. And then I went away to Providence, Rhode Island, where I did undergrad. Then I came back to DC and worked at Howard in med school. Then I moved to Philly for residency, then moved to Baltimore for fellowship. And any of those places, there was no mandate to say, in order to take good care of people, you need to learn about the community that you serve. Get out of the hospital, get out of the clinic, and get into the community and learn what's going on so that you have a greater grasp of what's happening. That, to me, is the beginning. We can go through all of the laundry lists of what you can do in real time. If you do not intentionally educate yourself about what's happening around you, all of that is for nothing, because we will continue to see these disparities in outcomes for programs that are implemented.
Community engagement is huge. And I think that it's so under-recognized, as you said, in places of academia, including Johns Hopkins, which we both are affiliated with. But I know that there are challenges in the way of getting to these solutions. You've given us so many ideas, and many of the ideas you also haven't given us because the people here on this call have it within themselves already, just have to invest in it. But I am particularly concerned about the things that might be getting in the way of those specific advocacy efforts. So what challenges, whether at the state level, the federal level, the community level, need to be addressed in order for us to, get rid, quite bluntly, of maternal mortality, morbidity, and these, again, disparities in reproductive health care?
There certainly are not, there are more than a few. Right. There are lots of things that
you don't have to go through all of them, just a few.
There are lots of things that have the potential to derail our organizing and advocacy. That's also not new, right? Folks who have power don't want to cede it. Right. And so that is just the circumstances in which we're in. We see this play out regardless of where you are, whether you're in a community-based setting, whether you're in academia, whether you're on the Hill in policy, right? Folks with power want to hold on to that power. And so that tends to be where the rub happens. When we look at policy solutions and political will or lack thereof, we have some amazing champions on the Hill that are doing work to move policy solutions forward around maternal mortality, right? And so we're deeply grateful for Representative Alma Adams and Lauren Underwood, who were doing just amazing work, and all of the folks at the Black Maternal Health Caucus. And then there's a collective of us who are working on federal policy, right? The Black Maternal Health Federal Policy Collective, who also does this kind of work. What do policy solutions at a federal level look like? But it isn't just the federal level that we have to address. What's happening at the state level, right? And so as we think about the levels in which people interact with our healthcare system, whether it is directly in clinical care spaces or these forces that are outside of us, like policy, like practice, like procedure, that shape the way that we can or cannot care for our community, then those are the places where you look for the levers to change. So yes, federal policy work and organizing, reaching out to your legislatures. The truth is that folks who are elected to Congress, to the Senate, they work for us. They're our employees. And so you have to think about it like that. If you had a staff person that was not doing what they were supposed to be doing, not following, your guidance as an employer, what would you do? You fire them, right? And so holding folks accountable, even the folks that we believe are on our side. I deeply believe that there are no two sides to this. right? There is human rights and there's not human rights. There's health and wellness, and then there is sickness and disease. And so for me, this idea that the Dems always get it right and the Republicans always get it wrong, or vice versa, depending on where you are, does not hold water. The reality is that everybody in policy spaces need to be held accountable. So we look at federal policy, we look at state policy, right? Because that also has the ability to impact. What kind of legislation is being put in place around perinatal health workers in your state? Are we allowing the kind of supports that people deserve in their community? Are we restricting it through licensure restrictions, physician-only laws, midwifery practice laws, doula practice laws, right? That are then restricting the kind of care that people can get. What's happening at the state level? What's happening at your institutional level? There are a lot of policies that are put in place at institutions from, years ago that are still being practiced that harm patients. One really clear policy, by way of example, is drug testing on labor and delivery, right? We know that Black and Indigenous women and birthing people are disparately tested and screened for substance use during pregnancy and the postpartum period. Our children are more likely to be stripped from our families, where CPS investigations are more likely to be launched. And when our children are taken into the custody of the state, they are more likely to remain in state custody for longer periods of time. All of those things, the inciting thing for this waterfall of destruction for community and family happens because somebody sent a drug test, because they were suspicious of someone. And we know when people are suspicious of somebody, who does it typically look like? It looks like me, right? And so understanding the data shows very strongly that there are equivalent rates of substance use during pregnancy, regardless of race or ethnicity, yet and still we see Black women and Indigenous people and birthing folks who are disproportionately targeted and tested. That's a policy. It's often a hospital policy. It is very rarely a state law, and it certainly is not a federal law. And so how do you get engaged in interrupting these practices? That means joining hospital committees and practice committees, right? We need to figure out ways that we can interrupt these as people who have deep clinical and public health knowledge to be able to stand up and speak back to that power. These policies were created by an individual or a group of individuals, and they can be undone. They were not written by Moses and when he came down and with the stone tablets, right? They can and should be changed.
Right. I just want to interject and say that there was a study that came out in the New York Times earlier this year, or that was publicized by the New York Times earlier this year, that highlighted that exact example that you are giving. And so part of me wonders, does that mean that we need more people in public health and in medicine who are doing research to prove that these observations are truly happening? We needed to have proof that maternal mortality and morbidity was as bad as it was when it came down to disparities. We need proof to show that hospitals are inequitably targeting certain populations. Is that something that I could surmise from what you're saying, or do you want to go beyond that?
The tricky part about the burden of proof is that it's also placed on the person who is most impacted and who's harmed. The idea that the burden of proof to show that inequities, discrimination, bias is happening is on the person who has experienced inequity, discrimination, and bias is a flawed approach. The burden of proof should not be going in that direction. In my opinion, we should presume and assume that inequity is happening everywhere, that bias is happening everywhere. And the burden of proof, it should be disproving it on the part of us, the people who have the power, right? And so this flip of the way that we think about the work, I think is necessary for us to really understand how to address it. We see this conversation play out, for example, in maternal mortality review committees across the country. And especially because the CDC added in this, if anybody's familiar with the forms, right, you have to, the purpose of MMRCs are to determine whether or not this death was preventable and to come up with solutions, right? How can we prevent it from happening again? What kind of systems need to be put in place? You have to identify the cause of death and then any contributing factors. Recently, one of the contributing factors was structural racism, bias, and discrimination. And the maternal mortality review committees are really deeply grappling with this, because what they're asking is, well, how does it really show? How can we prove that there was discrimination here? As if someone would be writing hate notes in the patient's chart that would prove discrimination or would be overtly discriminatory or biased in their writing. So we have to understand that so much of this is embedded in the way that we move within the system. The burden of proof cannot be someone writing the N-word in your chart to prove that you have been discriminated against. The burden of proof is on us, not on the patients. So the question about research and whether or not that doesn't necessarily mean that I don't believe that there is a utility in data collection and collecting this evidence, right? Because we don't count who doesn't count. And so the numbers definitely matter. The question becomes, how do we use it? What do we do with that? If we are simply performing research and asking these questions to engage in repeated efforts of disparity discovery, that's not how I want to spend my time. I actually don't need your data to know what's happening in my community. And so a move toward qualitative research is what I would support. Let's talk about what's happening. What are people's experiences within the healthcare system? How is that impacting their decision making? How is it impacting the clinician decision making within that context, right? So less about, how many Black women are dying, how many Indigenous women are dying, how does that compare to white women, which is always presumed to be the standard, right? And we can interrogate that all day for sure. But really understanding how do we go deeper than those numbers and really prioritize the lived experiences of people caught up in our systems.
Right. That makes me wonder then, as we look ahead, I think I'm a very solution-oriented person. I like to think in the positive and see the ways that we can move forward. But what developments, or really anything, what changes do you think will be coming in the field of reproductive health and maternal health with all this knowledge that we can take? What if you could look in your crystal ball, what's going to happen next?
I have no idea. I can tell you what I would love to happen next and what I think should happen next, but whether or not that is actualized, I think is debatable, right? I think that the challenge here and embedded in that question and really in our work is really not just like what do we want, but what can we do? Often so much of our energy and attention is tied to passable policies, like what can we move forward? Well, that feels like a pie in the sky. Let's move down a little bit and think about these small pictures. And I think there is a space and a place for incremental change for sure. And while we are working on that incremental change, it has to be steps to a larger strategy, a larger liberatory strategy, where everybody gets to be free, everybody gets to be well, because we all deserve to have that. So I don't know what these policies are going to look like. You dropped a link in the chat around the Momnibus, which is a beautiful, a lovely policy that has really been pushed and deeply informed by advocates and organizers on the ground. We're moving into the second iteration of that Momnibus. Policy change is definitely useful. We're thinking about, Medicaid expansion. And my hope is that more and more states will expand their Medicaid roles and rosters so more people can have access to insurance. That though has to be paired with access to actual care. Insurance has never guaranteed anybody access universally, right? And so understanding it is the insurance and it's the other piece that goes beyond, let me say, brick and mortar. So what we're not asking for is a clinic on every corner, right? That isn't the solution. But when folks walk in to those spaces, to any healthcare spaces, absolutely it should be co-located in their community with other services that are useful for community folks. And they should be received by people who look like them, who speak the language that they speak, who understand what their experiences are, who have those same shared experiences. When we look at programs where that is the model, we see amazing outcomes. And these inequities that we're talking about and have been speaking about for the last 42 minutes begin to improve. One quick example is work that's happening in DC at Mama Toto's Village. This is a community-based perinatal health center. And they hire folks who are from community because they are from community. And so they're helping people navigate the birth process, the prenatal care, registering for insurance and forms and all, but also transportation, helping people with their mental health. That is the model that I dream of when I think about how we fix what's happening in this moment. It is community responsive, culturally grounded, place-based care. It is not these ivory tower institutions that are sitting on the top of a hill with an idea about what community needs without ever talking to community.
Thank you so much for that example, because I was actually about to ask you, can you give us an explicit and specific example of this in motion so that people can look towards? And I'll try to find the Mami Toto Village's website to share in the chat.
Yeah, I can drop it for sure. Absolutely.
Yes. I again, what I'm hearing and what I want everyone to hear, oh, thank you, Elizabeth. What I want everyone to hear is that it sounds like there are a million little solutions everywhere that we can really invest in and investigate and make sure that people are putting resources towards in order to change the conversation around maternal health in general, not just for Black women, but for everybody.
Exactly.
And so
one quick thing to add to that, right? It makes me think again of that Combahee River Collective statement, right? There is a sentence in there that says if Black women were free, everyone would be free because it would necessitate the destruction of all forms of oppression. You talked about intersectionality earlier, right? Black women and other women of color living at the intersection of both gendered and racialized oppression. Black women and Indigenous women specifically also living at the intersection of economic oppression. We have folks who are living at the intersections on top of all of those things, race, gender, economics, immigration, right? Economic injustice. So the intersection of these things is really critical. But if we are organizing, then we have to organize the folks that are on the margins of care. We cannot create systems or solutions that just make access easier for the people who already have lots of access, right? But think about what it means to create a healthcare system that cares for someone who is living on a low income in a rural community, who is a person of color, who has an expansive gender identity, who wants to birth at home, right? All of these complications or seeming complications, right? That folks experience in their lives. What is the system that will serve them? Because I promise everybody else will be served too.
Absolutely. As you were speaking, I was almost visualizing, yes, there's people that are at the intersections, but that line, someone might just be on that one line, right? Yep. It doesn't mean that you're not affected. We're just seeing it almost amplified at those that are within the crosshairs of everything.
For sure.
You know, I before I go to a couple of the questions here in the chat, I'm wondering how can we as healthcare professionals and broader public health leaders stay informed, not just about the problem in maternal and reproductive health, but about these solutions. Yeah. Where does accurate information come from? What should we be reading? What should we be engaging with to make sure our minds are filled positively, but also realistically? And yeah, how can we continue to stay engaged?
Read, learn. And it's not just who you're reading or what you're reading. It's not just what you're reading, it's who you're reading, right? Really, when we're talking about racial inequity, it's so interesting that often we're talking about Black maternal mortality, and the research, the writing, the information that is being lifted up, that's being elevated, that's being celebrated is not research that is done by Black women and birthing people, right? And so really understanding what an investment of people who have shared lived experiences around this issue looks like. I would definitely recommend the Black Mamas Matter Alliance, which is a collection of a number of grassroots organizations that are doing this work in their own community. So pay attention to what you're reading. There's a beautiful website called Cite Black Women, because we know that Black women writers and researchers are not frequently cited in research articles and publications, right? And so there are folks that are writing about this work, folks like you, folks like me, who are continuing to do this work. How do we lift up those voices and see the power that we're holding so that we actually hear from folks that are doing work in community and not just talking about it in an abstract way? So definitely paying attention, being careful to unpack what you're reading and how you're reading it, especially when we're talking about race. Dr. Kamara Jones writes about race and epidemiology just beautifully, and talking about the ways that race is used as a proxy for all of these other things. And it is a poor proxy at best. It does not get us where we need to go. So if you find yourself writing your little paper and you start citing these, these disparities and Black women this and Indigenous women that, then really unpacking what that looks like. What are you trying to get at? How are you talking about this, about race in this moment, and doing some really deep introspection about that. I think that the last thing that I would offer would be really interrogating our own participation in these systems. And that is often the hardest piece of the work. I'm somebody who knew from the day that I came earthside that I was going to be a doctor and an OBGYN. That's the only thing I've ever wanted to be. And I had to, at some point, acknowledge my complicity in this system. The system that I knew when I began my medical education did not serve my community. And I can say today, it still does not serve my community in the way that we deserve. And what does it mean for me to continue to participate and engage in that system? And what is my responsibility to disrupt it and rebuild and recreate something brand new? One of the trickiest parts about white supremacy, and white supremacy is all around us. It's the air that we breathe. It's the water that we drink. And we often talk about the impact on people of color and Black people in particular on white supremacy culture. But one of the biggest impacts that it has on white folks who often hold the most power, right, because of our racialized value of human life in this country, is that it robs people of their imagination. So you can't even envision a world where everybody is free. You can't even think of a system where people can be pregnant and decide who they're going to birth with and have their baby when they want and where they want and do all right. It feels foreign to you, like unimaginable. And so in addition to doing the reading, doing the deep thinking, is really practicing that muscle of imagination, because that is something that has been robbed from all of us, but it is something that consistently shows up in Black movement spaces, because for many, many years, centuries, in fact, all we had was our imagination, the ability to dream of a better world. So what could it look like if everybody was practicing that as well?
I think that is so powerful. And for me, it sounds like that childlike curiosity that we all came into the world having, where nothing was off limits to us when we were a kid, right? You felt like you could be a superhero, and so you jumped. But that cynicism, in a way, as you grow, protects you and it keeps you realistic. But what I'm hearing is not allowing it to get to this point where you are so stifled of imagination that you can no longer look for solutions other ways.
Exactly. Because we hear it a lot, like, oh, that'll never work here.
Yeah.
Oh, we could never do that. The favorite term is, well, our patient population. Right. And so we hear that over and over and over again. And so those are the key terms that stifle your imagination. The other thing is asking why. Well, actually, why are we doing this like this?
Yeah.
Almost always it's because that's the way we've always done it. And you can trace it back to some obscure policy that some person made, maybe well-intendedly, that is continuing to cause harm. Ask those questions. I cannot sit here and suggest that working to dismantle and disrupt a system does not come at a cost. It does. This is a discussion of a divest, invest strategy. Right? It is not eliminate all the systems because they're poisonous and burn it all down. What does it look like to shift our energy, our capacity, our limited time and money and attention to something that is building, right? Something that is creating a new model of care. We can and we must do both. The cost both to community and individually can be great. It will be great as long as we don't. And disrupting comes at a cost to individuals. I've been disinvited to meetings. People don't want me in the room. I'm disruptive. I'm aggressive. I'm angry, if you couldn't tell, right? All of the usual tropes that we hear about Black women, right, are applied when you push back against these systems. So you have to be able to one, develop a thick skin, but a thick skin isn't enough. You have to be in community with other organizers, people who are your people, right? Who understand what you're fighting for. Nothing worth doing is done alone. It must be in community.
Right. On the theme of doing things in community and doing things through proactive advocacy and engagement, there's a question that came up in the chat about the power of words when used for voting purposes. And before I ask the question, I also want to point out and highlight something you had said much earlier in our conversation. It sounds like voting, an election year is coming up this next year. Voting seems to be one way of showcasing our power as public health professionals and people that want to improve maternal and reproductive health. And so I'm just going to highlight that again. But this individual said, can you talk about the power behind the word, specifically abortion? And they're thinking of how Kansas rejected a proposed state constitutional amendment last year, and Texas expanded abortion to serve ectopic pregnancies this past year in August. Both of the advocacy campaigns for these situations rarely, if ever, use the word abortion. Do you think that that's had an impact or a result on the subsequent policies? So basically, the language we're using, how is that changing our ability to move forward?
Language is so important. And it's so inadequate to describe so much of our lives, right? And so I think a lot about words, about the words that we use, about the words that we don't use. So thank you so much for this question. I think it absolutely has an impact, but that isn't to say that we should or shouldn't be doing it this way or a different way. We know that the word abortion is deeply stigmatized because it has been co-opted by folks that are attempting to eliminate access to pregnancy termination, period. But we also know, as public health folks and medical providers, that abortion is actually a medical term. And so I think that there is an opportunity here to reclaim that, but that's going to be culture shift work. It isn't as simple as saying we need to say it more and more and more because that alone busts stigma. It actually doesn't. And in many communities, it deepens it and really will eliminate the opportunity for entry into this fight for folks who cannot seem to get past it. So it is the message and the messenger, and really being nuanced around it. I don't have a clear answer. There isn't a cut and dry of like, we should always use it or we should never use it. But I believe that there is a time and place for that. And even those of us who have been deeply entrenched in this work for many, many years find ourselves deciding and determining based on the context we're in, what is the best language. I don't talk to my child in the same way that I talk to an adult. Right? We use different words, we use different language, and this isn't to diminish anybody's capacity for understanding, but only to figure out how can I say what I need to say so that they actually hear it, so that they are moved to change. Sometimes we can do that with a hammer, and sometimes we just need like a little gentle pressure. And so really being flexible and iterative in how we're having these conversations, when we're having them, and what our end game is. What is our goal? Right? If your goal is eliminating abortion stigma, then you may be more inclined to say, I'm going to use this word as much as I can. I'm going to shout my abortion story. I'm going to join We Testify and talk about my abortion. I'm going to support people who have abortions, and I'm going to say abortion, abortion, abortion. For other people who are working in communities where abortion is very deeply stigmatized, may say, we want to bring people to the table, so we're going to talk about this in a different way. Maybe their entry point is immigration. And when they get there, we start talking about the impact of immigration laws on access to abortion for undocumented folks. And that is the entry point. Whether you use the word abortion or not, I think is dependent on the context and what you're seeking at the end of this conversation. But we have to practice it too. We don't talk about it enough. I agree. In the same way, we don't talk about racism enough. And so people don't know how to talk about it because they haven't been trained to talk about it.
Yeah. Again, I'm hearing something that is very oriented around the community in which you're engaging with, and how that both is a challenge, but also great space of excitement. I'm going to ask this last question, and hopefully this will be a good way to end our conversation looking forward and looking at solutions. From Juanita here in the chat. How do you measure change with an individual organization? Again, recognizing that there are so many million little projects going on. How do you look at the progress you're making, and what effects new policies have on that specific population if it's very different from another population elsewhere? What is our measurability scale, if at all, and is that important? Is my add-on.
I think it is important, and I would offer that the how or the what that you measure is deeply impacted by the person who's asking the question, right? We see this in study design all the time. The person who's asking the question is the one that designs the study. Usually it's a top-down approach. If the change that you're looking for is community-based change, if it's impacting the individuals in your community, the change determination, the measure needs to be determined by the person that is impacted by these policies, not by us who decide, well, actually, we think that it should be A, B, and C. We go through this whole process, we engage in all of these practices, we roll out a new policy, only to find out that's actually not what the community needed at all, right? We're saying that we believe you need transportation here, or we believe that you need contraception access. This is a perfect example. We believe the reason why young Black and brown girls under the age of 18 living in specific communities in DC don't use long-acting reversible contraceptive methods is because they don't have access to it. Engaged in this whole process and project around it, by the time, at the end of which, started talking to folks in community, and universally they said, no, actually, we could get it if we wanted it. There are lots of reasons why we don't use it. So how are you measuring it? Who's asking the question? Who's informing it? Right? And what does that look like? This is not going to be like a Likert scale, right? Either you've done good or it's terrible. There's going to be a lot of missteps, and that's part of it. So part of creating change and then measuring that change is grappling with accountability around failed or ineffective policies or harmful policies. What we see sometimes we have an idea about the way something is going to happen. I was working at a health center and they wanted to put in a policy around governmental ID checks. And it seemed like a good idea. It was the safety of the clinic. They were doing it. But ultimately, in conversation, we discussed the fact that it is eliminating access for a number of people. So it had this one benefit, but the other one, the cost was too high. So really asking yourself, there's a beautiful checklist of questions. I think it came from the Consumer Health Foundation around racial equity that looks at this, right? What is the policy that you're putting in place? Who designed the policy or practice, right? Who did this come from? Who is at the table? Who's holding the power? Who's missing from the table? So there is a rubric that you can follow as a support guide in order to ask those questions. But I think the people who are in the room are often the biggest influence when we're thinking about where we want to go and how do we measure our success and our progress.
Absolutely. Thank you so much. I just want to say that this has been, I'm going to re-listen to the recording. This has been such an enlightening conversation. And I want to, oops, sorry, second. That's my timer. This has been such an enlightening conversation. And I'm so humbled that you were able to share your time and your words of advice, because I think that this is not just applicable to the Black maternal health crisis that's happening in our country, but it's applicable to every public health conversation that is happening within the walls of Johns Hopkins and outside of it.
Absolutely.
And so I want to just say thank you for your time. Thank you for your insight. And I'm really hoping that the audience really appreciated what was shared, and hopefully we can continue to engage with you, whether that be with Physicians for Reproductive Health or in other ways, in other spaces. So thank you so much, Dr. Perritt, for teaching us and reminding us that we collectively have work to do.
Thank you so much. It was an honor to be here. Thank you all for joining. I look forward to continuing the conversation. Thank you.
Absolutely. And I'll turn it over, I guess, to Elizabeth to kind of take us out as many of the thank yous are coming through. And also, I guess maybe I can ask this. If people wanted to be in touch with you or learn about some of the work that you're doing with your organization, is there a way that they can maybe not contact you, but contact a group that is represented?
You can check us out on prh.org. You can follow us on all of the socials on the internet at PRHDoc, and you can follow me at ReproRightsDoc So those are probably going to be like the easiest ways to get linked in. Of course, Black Mamas Matter, we already have the link in there. I really encourage you to reach out to follow them, to follow their work, along with so many other organizations that you'll see listed underneath their umbrella that can help really deeply inform it. So, but if you want to reach out to me, PRH is the best way to do it.
Perfect. Well, thank you so much. And I think with that, I will adjourn this lunch meeting.
Great.
Thank you, everyone.